Anyway, thank you very much for inviting me. It's interesting because India has 100 times the number of ophthalmology academic centers than Canada does. So every time I get invited to speak in India, I'm amazed that you invite me. And of course, I'm very much honored to take part in your wonderful symposium. So I'm going to talk about bilateral cataract surgery. And this is one of the things that I like to talk about in my sort of latest thing that I talk about a lot. These are my disclosures. None of those, of course, really matter. My real disclosure is that we just wrote a book on immediately sequential bilateral cataract surgery, which will be out in September, I hope, or perhaps October. And wherever I show you this logo means what I'm talking about is in the book. So it's interesting if you look at the history of cataract surgery in general, that we seem to be all moving towards bilateral cataract surgery. And you know, in 1750 BC, the Kodur Hammurabi first talked about cataract surgery, didn't describe how to do it. Cataract surgery was first described as couching by Susutra in the Himalayas, just coming down towards Delhi. And it's interesting that that's where things started. And the next big change really came in France when Daviel, 2,000 years later, talked about extracapsular surgery. And then 200 years later, Ridley talked about intraocular lenses. And then 25 years later, Kelman did phaco. And then things went on. And you see now there are 3 branches. A lot of us just took phaco to do bilateral cataract surgery. Some went through doing femto. And now Sandu-Kuyut's M6 are starting to do bilateral surgery, but there are some concerns with that, which I'll talk about as we go along. So what I want to tell you is we're all taught that cataract surgery should always be done unilaterally, and always was, but that's really not quite true. The history of bilateral surgery is that in every generation, the methods that we use, ideal, let's say for cataract surgery, evolve from what our scientific paradigms are, and often we don't know those because we don't look back long enough to look at the history of what we've learned. And it's interesting, one question I always ask myself is, where did couching come from? Who forgot the crazy idea of sticking a needle in someone's eye and shuffling it around to try to mess up the lens? And the idea is that the Latins believed that the cataract was a suffusion of a humor between the lens and the cornea and the iris, which was really in this O space here, the locus vacuus. And you might think, well, that was a long time ago, over 2,000 years ago. But if you look back and you see what was written by Vesalius in his book in 1543, he still made drawings of an eye with a locus vacuus. And so it's not surprising that patients come to us and tell us that they think we're basically removing a membrane in front of their lens when we do cataract surgery, because that came from thousands of years of believing that the cataract was a suffusion of a fluid which congealed in front of the lens, and the lens was really the locus of vision. It was only after 1700 that people realized that cataracts were a clouding of the lens. And that came with Daviel very shortly after 1700, starting to do extracapsular surgery. Interestingly enough, Daviel did his surgery as bilateral surgery. And he always did the left eye first because that really keeps you from moving things across the right eye, because most surgeons are right-handed. And it's that way, if you always do the same eye first, you make fewer mistakes. And by 1756, Daviel had performed 434 extracapsular procedures, and he said that 88.5% of them were perfectly successful. That is unbelievably good when you consider the success rate then of cataract surgery was about 20% or so. And so Daviel really was one of the really great changers in ophthalmic surgery in its history. So if that's the case, if people were doing bilateral surgery then, why do we perform unilateral surgery? Well, cataract surgery was really very brutal prior to having anesthetics, which came about in the late 1800s. And bilateral surgery was generally done hoping that at least one eye would see, and no one really knew that the problem of infections could arise. And often the last procedure someone would have done in their life was cataract surgery, and they hoped they would at least see somewhat out of one eye afterwards so they could see their grandchildren, and they hoped even more so to survive the procedure. There were some surgeons who were not terribly ethical. This guy I showed you, John Taylor, performed routine bilateral cataract surgery, advertised great. He showed up in towns to do surgery, and then promptly left before the results became apparent. Among his blinded patients were composers Bach and Friedrich Handel and many others. Unfortunately, Bach died blind 4 months after his unsuccessful bilateral couching in 1750. So then what happened is the germ theory of disease came about, and we owe it to these people who really taught us a lot and really helped medicine everywhere. And it's unusual that we had a Frenchman, a British, and a German coming together, which has probably never happened since then, that those three countries have got together with anything. But Louis Pasteur first proposed the germ theory of disease, and Joseph Lister then said we should have aseptic operating rooms, and Robert Koch then proposed his postulates to show what actually was causing the infection. The problem was that no one believed these three people. It was only after the First World War when people found out that there were more people dying of infections in the First World War than died of their injuries. And of course, the influenza pandemic after the First World War killed more people than the whole First World War did. And so only about 1920, 1930, the people seemed to think that infections really were a big problem and began to address them. And it was then that we began to look at doing unilateral surgery. And we really owe the return to the ability to do bilateral cataract surgery to these people, to Jim Gills and Howard Gimbel, who in the 1990s expanded on their work in the vitreous of Golan Payman and began to inject intracameral drugs. This opened the road to the Swedes looking at their problems and trying to address it and what they developed. So what the Swedes did was in 1990-1995 at St. Erik's Hospital in Stockholm, Sweden detected a very much higher rate of post-op endophthalmitis than they were reading about what occurred commonly in the United States. And so they began to do various studies of intracameral antibiotics, and in January 1996 began to use intracameral cefuroxime and also added to it sometimes ampicillin to cover enterococcus. And they found they reduced their infection rate from 0.26% to 0.06%. So the ESCRS, as we all know, a number of years later, copied the Swedish study and then began to promote the use of cefuroxime around the world. So at that time, we began to realize, a number of us around the world, that we could do bilateral surgery. Our infection rates were extremely low. We were all using intracameral drugs, and we thought we should do that. And this small group of 9 people put together this society to look at bilateral cataract surgery, not so much to promote ourselves, but we thought that everyone would start doing bilateral cataract surgery, and we'd like to make sure, as the innovators, that it was done safely. One of the ones who was doing it and didn't join our society was Sulevi Keipiainen, who started at the same time as the rest of us in Finland. And I guess because the Finns speak a funny language and keep to themselves most of the time, he never joined our society, but he was also one of the great innovators. One of the best things that our society put forward is this decalogue, the 10 points of how you could do bilateral cataract surgery safely. And we hope that people who undertook bilateral surgery after us would follow these guidelines, or really we call them suggestions, to do things safely. So the reality check is the biggest thing that people promote as saying why they should not do bilateral surgery or they're afraid of it is bilateral simultaneous postoperative endophthalmitis. So what really is the risk of this? Well, if you follow that decalogue of treatment and careful protocol of bilateral surgery, the risk we see of bilateral infections simultaneously is about less than 1 in 100 million. So what is that compared to other risks? Well, the deaths from general anesthetic is 1 to 100,000, which is 1,000 times higher than the risk of bilateral simultaneous post-op endophthalmitis. The risk of winning the lottery in Canada is 7.2 times higher than the risk of getting BSPOE. And the risk of death driving 1 kilometer on a United States road is about the same. 1 kilometer means getting up, getting in your car, perhaps going to the corner to buy a bread. So the risk of dying in that car accident is about the same as the risk of getting bilateral simultaneous post-op endophthalmitis, which of course is not very high. The first university and city to totally adopt bilateral cataract surgery is Quebec City, and I joined in the seminar, which was in French, so most of you probably did not join it, in June 9, 2020, when Marie-Ève Legarrey talked about what they had done in Laval. They copied the things that ISBCS and I had put forward, and I promoted them, of course, in Canada. And they used the antibiotic prophylaxis that I recommended. And they have gone to where, by default now, everyone gets bilateral cataract surgery in Quebec City. And they've now done over 24,000 eyes, probably 25,000 by now. And they've reported by using the intracameral moxifloxacin diluted, which I've promoted for years, that they get an infection rate, which is very close, 1 in 14,500, what we reported before at 1 in 16,000. These are the 2 lowest infection rates reported in the world. So here is how you prepare it. And I suggest to you that if you have a choice, try to use this dilute method of preparing intracameral moxifloxacin. because it is much more effective than anything else that has been done so far in the world. I looked at the various papers on this and the data, and it's more accurate. It's safer because you don't get any toxicity to the posterior iris if you inject it behind the iris, and is more effective because the dose you have in the eye is much better and is more predictable when you inject a large volume than a small volume. So this is what I suggest that you use because we have the best data of anybody in the world so far. There are numerous benefits of bilateral cataract surgery, and you can go through all these. I won't detail every single one of them, but basically the patients adapt more quickly to their bilateral pseudophakia, no matter what kind of lens you use. They have reduced number of visits, so less spread of COVID-19. They don't have anisometropia, so they don't fall, they don't break their leg. Even amblyopic eyes get considerable benefit and do better and better over time once you correct their eye. And often patients with amblyopic eyes will never come in to have the amblyopic eye operated on. So that for many, many reasons, this is a better way to do cataract surgery. And I think all of us will be doing bilateral surgery as our default cataract procedure reasonably soon. Is spreading very rapidly around the world. What I want to suggest is that we all do it very safely. And so when is it safe to embark upon bilateral surgery? Well, when every single step of your procedure has been perfected. So you have to have a very low incidence of posterior capsule rupture, of infections, of all the various things. And you must have all these techniques that I list here down quite cold and quite specific and working for you every single time. So for example, I'm not bragging, but I just did 40 operations the last couple of days. Every single patient was perfect with no problems. That's what you have to have. You have to be able to predict that you can do these patients and you go through them and you won't have problems. And then you can go and do bilateral cataract surgery. So the then question is, what kind of procedures are good for bilateral cataract surgery? Well, phaco is the one we started with and we've all done for a long time. It's a very mature procedure. The small incision reduces infection risk. Antibiotics reduce the infections to less than 1 in 5,000 in all recent reports. And if you follow our ISBCS general principles for excellence, the Decalogue, which we call the 10 Commandments of bilateral surgery, you have very low risks in the complications for surgery. And it's becoming rapidly accepted. With femtocataract surgery, the procedure is now also becoming very mature, at least in North America. It's better than phaco for brown or white cataracts, for pseudoexfoliation, for posterior polar cataracts, for fibrotic anterior capsules, for myotonic dystrophy. And every couple of years, we're getting more and more types of cases where we see significantly better results with femtosecond cataract surgery. One of the current debates is whether we should do femto-phaco, or femto-phaco. I tend to do all femto-phaco now because our complication rates are pretty close to zero. The other things that we got with phaco surgery hold over in the black because they're the same for femto. There are some concerns with M6. Manual small incision cataract surgery has a larger incision, which leaves a greater risk for leakage and possibly infection. It's often performed in camps, which are not quite as sterile as the operating rooms. And because of the tight budgets, there are often restrictions in doing this for poorer patients, and so the risk is probably higher. And I think the patients, their families, the whole setup may not be quite as vigilant. So there's a concern with manual small incision cataract surgery. So at least for phaco and femto, there's no problem in doing bilateral surgery. For M6, it has to be worked on a bit more and straightened out before we can all do bilateral surgery. Globally, the choice of immediately sequential bilateral surgery or delayed sequential surgery depends primarily upon money. And I suggest to you that as India and countries that were before considered to be third world, but now are often leading in innovation and new things in cataract surgery and everything else, as that country gets wealthier, they will proceed to do bilateral surgery the same as the rest of us do. So in summary, the global history of bilateral surgery is that it was the preferred method of cataract surgery throughout history. Cataract surgery was horrible, with poor success rates and no IOLs. The germ theory of disease and the unavailability of any antibacterial made bilateral surgical procedures of any types risky, and therefore, for about 100 years, people were not doing bilateral surgery. But the development of intracameral antibiotics, the added to extracapsular surgery of Daviel, intraocular lenses of Ridley, and Kelman's phaco have allowed us to return to bilateral surgery safely. And most things are now being addressed extremely well. After infection prophylaxis, we now must assure that we have refractive accuracy and funding. And with those things accomplished, there's no problem in doing routine bilateral cataract surgery. Thank you for your attention. It's a great pleasure to take part in your meeting.